Good morning. Oh, there we go. We'll try that again. Good morning, everyone. And welcome to the 2016 Spring Medicare Advantage and Prescription Drug Plan Spring Conference and Webcast. My name is Stacy Plizga, and I will be your moderator for the day. This morning, we are gathered here at the CMS Central Office Auditorium, where the webcast is originating from. And we have a number of CMS experts who are going to share their experiences and their knowledge with us throughout the day. In addition to the approximately 200 individuals we have here on site with us today, we have over 3,500 who are joining us from the webcast, so welcome to all of you. In fact, we have individuals from 49 of our 50 states and also from Puerto Rico. We would like to welcome all of you and thank you for joining us today for this very important event. Now, before we get started, I wanted to go over a few logistic items with you that may be helpful throughout the event. Webcast materials are available at the CTEO website that is listed on the screen. If you have not done so already, you can log into this site and you can download the presentations to follow along with the presenters today. If you are having technical difficulties, we do have staff members who are available to assist you. Please use the mailbox at CTEO tech support at cms.hhs.gov for your technical question or concern. The Medicare Advantage and Prescription Drug Plan Spring Conference and Webcast will feature polling for end-of-session evaluations and also to allow both our in-house and our virtual participants to interact with the presenters throughout their presentation. There are a number of ways that you can participate in the polling. You can respond to the polling questions from any mobile phone by sending a text message, or you can respond from any smartphone, tablet, or computer by visiting the Poll EV web address. So you may be wondering, well, how do I join? I want to participate in the polling. Well, if you would like to participate via text message, you must first join my session. So if that's the way you want to participate, please grab your cell phones and select your text message screen. We'll do this together. We'll get you all set up. You're going to create a new message, and then you are going to type 22333 into the recipient or the to box. Once you do that, you're going to type CMS 2016 Spring, and please note, this is not case sensitive, it can be upper or lower, into the message box. CMS 2016 Spring. And then send your message. This session, once you do that, it remains open for the entire day, so this is the only time that you have to do that. You're going to receive a message, oh, I heard someone's phone ding, that says you have joined the 2016, CMS 2016 Spring session, so you're set once you see that message. All right. There is, when the presenter presents you with a poll using your cell phone or your smartphone, you are going to enter your response each time the poll is conducting by entering the letter that corresponds with your answer. And then you hit send. That's how you respond. It's pretty easy. Okay, there are what we call end-of-session evaluation questions when you'll be able to evaluate the presenter. Now, these are slightly different from the questions you'll receive during the presentations. So follow along with me here also. And we'll go through this again when we actually do it later. But When you are prompted by me, the moderator, at the end of the session, then you, on your cell phone, you are going to respond to the question, I would like to evaluate session 1. Okay, we're not doing this now, but we'll do it later. And you respond by putting an A in and sending an A via the text message. And then you're going to receive a link back. And it's going to say, hello, please evaluate the session using this link. You'll go ahead and copy and paste that link or click on that link, and it'll take you to the Poll EV site. There, you will receive, on your phone, it'll say end of session evaluation for session number 1. If you want to join, press start. So go ahead and choose start. Then the next screen you're going to see is the actual question. You will receive 4 questions, one at a time. You have to answer each question in order to proceed to the next. So you will enter the letter that corresponds to your answer, and then you will press next, and then you will move on to the next question. After the 4th question, you will see at the bottom it will say finish. Go ahead and click on finish, and that will submit your responses. If, excuse me, you would like to participate via web browser, for those of you who have, you want to do that on your smartphone, your pad, your tablet, iPad, or even your computer, you're going to go to this link. So go ahead and put this link in, www.pollev.com/CMS 2016 spring. Again, this is not case sensitive. Once you do that, you are connected, and you're connected for the day. And you will get a screen that just says that, that the polling session is not open at this time. So don't worry about that. The polling questions will appear when either the speaker or the moderator prompts them to appear. Once they do appear, you just enter your answer and submit it. Pretty easy. Again, end of session evaluation questions for those of you who would like to participate using your computer, your tablet, smartphone. They're very similar to that of those who are texting. Make sure you're logged into pollev.com/CMS 2016 spring. And then when you're prompted, you are going to choose yes. If you look at the screen that is up there, it says, I would like to evaluate session number 1. Okay, if you click yes, there's a little green box at the top that'll pop up, and it will say, hello, please evaluate the session with a link. You need to click on that link. Now, very important, this box doesn't stay up for long, so you have to pay attention. If you miss it, go down and clear your response, and then click on yes again, and then that green box will pop up. Go ahead and click on that link. And then it'll take you to the screen that says end of session 2 evaluation questions survey, and you'll go ahead and you'll click start again, and then you will get those questions one at a time. You will click next after you enter your answer and finish when you are completed. I have people responding. So we're going to try this together, and some people are doing a great job because I've already got responses up here. So those of you who have connected via your text, you can go ahead and answer the question, which song best describes you today? Is it A, Shiny Happy People by REM? Is it B, Working 9 to 5 by Dolly Parton? C, that creepy doo-doo doo-doop sound that you hear when Jaws is about to attack? And lastly, D, Raindrops Keep Falling on My Head by B.J. Thomas. So go ahead and enter your response if you have not already. I'm glad to see that we have lots of people participating. However, I'm not glad to see that a lot of people are feeling like it's a working 9 to 5 day by Dolly Parton. I don't know about you, but when I walked in this morning, it more felt like raindrops keep falling on my head. So I was hoping it was going to be Shiny Happy People, but, you know, tomorrow's a new day. All right, so great job on that. It looks like we've got lots of people connected, and hopefully we will change that working 9 to 5 to Shiny Happy People by the end of the day. All right, and if you have presentation questions, we look forward to everybody participating today, whether you are here in the audience or you are virtual and viewing us via the webcast. For our webcast participants, if you have a question for one of our presenters, at any point today, go to the SurveyMonkey link. It was emailed to you last night with polling instructions, and it's also posted on the CTEO website, and enter your question and contact information. We will either answer these questions today during the session Q&A or at the very end of the day during the open Q&A session. For our in-house participants, we ask that if you have a question that you stand up and walk to the center aisle to one of the microphones that is placed there, and when prompted that you do ask your question. It would be helpful if you introduce yourself and where you're from and speak into the microphone, that way our viewing audience can hear your question. And finally, if you have a technical question related to polling, if you're having difficulty with that polling we just went through, you can send an email to tsanderson@providerresources.com. And we will get back to you very quickly with a response. If you have a technical question regarding the conference or the webcast, you can send an email to CEO Tech Support @cms.hhs.gov. We are glad to have all of you here today with us. Our agenda today is packed with CMS experts who are excited to share their knowledge and expertise. So let's go ahead and get started. Kicking things off for us this morning, we have the Deputy Administrator and Director of the Center for Medicare. Please help me welcome Sean Kavanaugh.
Thank you, Stacy, and thank you everyone for joining us today. Welcome to CMS, welcome to the conference. We're glad to have you here, including folks who are joining us by webcast. I wanted to take a few minutes just to do a few brief things. First and foremost, I wanted to thank you. The Medicare Advantage and the prescription drug programs continue to be very popular among our beneficiaries. They give their beneficiaries choice of how to receive their services. They give them a choice to save money on cost sharing, and they protect them from the high cost of care. And consistently, they're providing them with high quality care. These are all things the agency cares about, and we appreciate your partnership in helping deliver on those promises to our beneficiaries. So thank you for another great year, and we're looking forward to working with you in the year ahead. Briefly, I just want to talk about what we accomplished in the year leading up to now. And I wanted to focus particularly on two areas. One is the risk adjustment changes we made in the Medicare Advantage program, and the other is the introduction of socioeconomic status adjustments to the star ratings. Clearly, other things went on this year, but I wanted to call these out because these are emblematic of the way we're trying to work with the industry. In each of these areas, we tried to be deliberate about our work, meaning doing research, trying to find empirically what the right answer to each of these was. We tried to be transparent in that we shared the research we were conducting, and we asked the industry to share with us any research or data that you had. And we tried to be collaborative. In addition to sharing data, we tried to provide you with additional time to engage with us on these important issues. And as you know, with the rate notice and call letter this year, we made important policy changes. But we hope you're picking up that there's a cadence to this work, that whenever possible, we want to engage with the industry, solicit your ideas for change, and work with you as we move towards possibly changing policy. In that respect, I'd like to talk about a couple things that could be on our agenda for the coming year. First and foremost, and not that we have specific policy proposals, but we will be working with the industry and seeking ideas on how to control the high cost of drugs in Part D. I think collectively we've been successful in holding down the premiums for our beneficiaries, but we all know that the costs of the program as a whole are growing at a very high rate. And so we look forward to working with you in that area. We also, as we indicated when we did the star ratings and socioeconomic status adjustment, we indicated that the provision and policy change we enacted was an interim adjustment. because the Congress had instructed our colleagues in the Department of Health and Human Services in the Assistant Secretary for Planning and Evaluation to study this issue further. So we look forward to working with you as ASPE publishes their work and possibly proposes additional changes, but we'll all wait and see. But we'll be working with you openly and transparently on that as well. A recent issue that sort of caught us by surprise, but we do very much want to engage with the industry about, is what is the right relationship between audit findings and star ratings? As many of you know, we had a policy until recently that plans under sanction had their star ratings automatically reduced. We had a case before us this year where, as we drilled down on the implications of that, we became less and less comfortable with the policy, and we suspended it temporarily. What we'll be doing is working with you, and we solicit your ideas on how do we rebuild this policy in a way that makes sense. Do we more closely align audit findings and star ratings, because audit findings are measuring, in many cases, things that are important to our beneficiaries? Or do we pull them further apart with the understanding that star ratings should be more about clinical quality and less about operational excellence? So in the fall, we'll be soliciting your ideas, but we're open at any time to hear your thoughts on that area. One of the topics that's subject to the panel today, I imagine, will continue to be a focus of the agency, and we hope a focus of yours, which is opioids. We all know the epidemic and the cost of that epidemic in lives and dollars, and we think the Part D program with CMS and the prescription drug plans working collaboratively have really made important and measurable progress in that area, but much more needs to be done, so we look forward to working with you. So that's a preview. Oh, one last issue I would say, as you may have noticed, we think the cadence and the intensity of the work around RADV will pick up in the coming year, and we look forward to working with you. There's still some policy making to do there. In addition, you may have seen we entertained the possibility of soliciting a contractor to bring a RAC into the RADV work. As many of you may know, the law actually requires that we introduce a RAC into the Part C work, and we thought RADV, given that RADV has a structure around it and an understanding between the industry and CMS, might be the right way to introduce it. So those are sort of the top line subjects we'll be thinking about as we enter the fall and begin thinking about policy making for next year. As I said, we want to be deliberate about these things, we want to be transparent, and we want to be collaborative. So we look forward to hearing from you on these subjects, and also, more importantly, on our other subjects. If you think there's other things we should be doing to improve these programs, we welcome your comments. So thank you. You've got a big agenda today. You've got a lot of experts from our team, so I hope you enjoy it. I hope you learn, and thank you again for your work on behalf of our beneficiaries.
Okay, thank you, Mr. Kavanaugh, for sharing with us and kicking things off for us this morning. Our first speakers today will offer suggestions on how to work collaboratively with your account manager and share vital information the account manager needs to assist in process improvements. Providing suggestions to build effective relationships from the Kansas City Division of Medicare Health Plan Operations is Judy Flynn, and from the Seattle Division of Medicare Health Plan Operations, please help me welcome Brenda Suter.
Good morning. Good morning. Thank you, Stacy. So to get it straight, I'm Judy, and she's Brenda.
I'm Brenda.
And we're going to just start out today with a short story. I'm going to go to the first slide. So we're going to talk about building collaborative relations, which many of you have already with our account managers. But I thought we'd start out today illustrating something that really helps demonstrate why I have a passion about managed care and the work that we do with our account managers. So I've been with the federal government for 12 years, and I actually, before that, ran a small Medicare HMO in Kansas City. And I was the director, and one day the call center director called me and said, we've got an issue. We have a beneficiary that our call center reps can't understand. She's very, very hard to understand, and she's very frustrated, and we can't seem to help her. So he shared her phone number and address with me, and I gave her a call. And she was very frustrated and very hard to understand. And her husband finally got on the phone and explained that some problems she was having. And I asked if I could stop by on my way home. I noticed the address was along the way on my way home, and introduce myself. And he agreed. And so I stopped by their apartment that afternoon. I knocked on the door, and Eric, her husband, answered the door. And when I went in, it wasn't very long before I realized that he was almost totally blind. So we have this dynamic couple with him totally blind, and her with very serious cerebral palsy. And they had recently moved to Kansas City and had really struggled with finding a provider that could help her. She was suffering with extreme spinal nerve damage and ongoing muscle problems. And well, they had enrolled themselves into our plan online, and though she had serious cerebral palsy, she was extremely intelligent, and really the brains behind the two of them. Anyway, they had enrolled, and then when they called to try to get appointments with the doctor, the people kept hanging up because they couldn't understand her. So I went back to the office the next day and got with our nurses, our medical management team, and they immediately contacted a provider that they knew would work really well with her, set her up with an appointment, arranged for transportation, and really got her with a doctor. The doctor then got her to a specialist who looked at her spinal nerve problems, and they actually put in, and I'm not clinical, so bear with me, they put some kind of a stimulator in her spine that allowed the pain to be manageable, and it made a really difference in her life. And they also connected her, our nurses connected with her on community services that could help some of the things. When I was there, I noticed there was a scooter in the corner, and though she could walk, she couldn't walk very far. She could walk from a chair to the table and table to the bathroom. And this scooter was the thing that allowed her to really live. And so we repaired the scooter, which is what she wanted, and connected them with other community services. So I stopped by a couple of months later to see how things were going, and we had made such a difference in their life. When I knocked on the door, her husband answered, and they had a new friend, and it was a seeing eye dog. And he was training a seeing eye dog that was helping him get to and from their apartment to a bus, and he had been promised a part-time job, and he was so excited in how their life had changed. And that so demonstrates to me the passion of what we do in the managed care world to make a difference in people's lives. And I'm sure many of you have similar stories. If you don't, go see your nurses. They all have them. It is what we do that really makes a difference. And it brings passion to me about really developing good account managers to work with you to always move towards that excellence. So Brenda's going to talk a little bit about the structure of account management.
So our goal today is to share suggestions on developing collaborative, effective relationships between plans and their account management teams. But first, a little bit of background information about how we work with parent organizations. Each parent organization is assigned an account manager located in one of our 10 regional offices across the country. And the name of each of those offices is based on the city that it's located in. But you may also hear a regional office referred to by number. And like the sun, the numbers start in the east, so Region 1 is Boston. They move west to where the sun seldom shines, and that would be Seattle, Region 10. And that's how we organize our work, is having our account managers located across the country to work collaboratively with you. And our account managers work every day to improve plan performance through a range of activities. And those include assisting parent organizations in their operations, monitoring metrics for compliance with CMS standards, escalating issues as appropriate. And account managers regularly meet with you, sometimes once a month, sometimes twice a month, sometimes daily, depending on what issues are happening. And they really work to understand your operations and your organization. They issue first-level compliance notices, and they also recommend plans for audit. Account management is a team activity involving collaboration with the Center for Medicare here in Baltimore and in each regional office, plan analysts, caseworkers, and other regional office staff. And we all work together to achieve our goal of providing beneficiary access to high-quality care. Now, number 10.
So you might want to count down with us. Number 10. And by the way, the slides are related to our regional offices. So the picture you see is Seattle, number 10 region. And this slide is about being open and cooperative. And we promise to be open and cooperative on our side, too. So when you hear from an account manager, when they call you unexpectedly and you say, oh my God, what have we done now? Please be aware that we always want to assume positive intent. We want to assume that we are all in the boat together to try to get everything working right. And so we just ask that you be open as you investigate something and share with us. When you have a problem, let us know, and we're going to talk a little bit more about that. So that's number 10.
All right, number 9, and this is the San Francisco Regional Office, and it's share feedback during strategic conversations. First, some background information. A strategic conversation is a discussion held by account managers with their Part C and D plans. And the account manager shares information on a particular topic. We choose topics based on areas where we want to make sure that all account managers are having a discussion with their plans on something, or we need feedback on how to improve processes or just check in and see how things are going. So the account manager asks a standard set of questions designed for the strategic conversation, and the answers back from the plans are summarized. And the feedback is then shared with the group that we're working with, typically here in Baltimore at the Center for Medicare, but not always. We also have worked with the Center for Program Integrity. And then that information is used to improve processes. And a strategic conversation is a tool that we use to provide educational information, facilitate discussion, and collect feedback. For example, one strategic conversation was on appeal medical records. Plans indicated that obtaining medical records can be challenging. And a strategic conversation was developed in collaboration with the Division of Appeals Policy to discuss some of the barriers that impacted plans' ability to obtain medical records. And they wanted to just get a better understanding of the challenges that you all face when you're trying to request medical records and what process you use to request medical records. And the feedback was then used in order to improve the process and make it easier for you to obtain medical records. Our pilot strategic conversation was on the Common Conditions and Best Practices HPMS memo that helps plans improve compliance with CMS regulations. It assesses risks in their organization and really to help improve audit outcomes. And it provided a way for account managers to discuss the memo with plans if they hadn't already, and talk about some of the issues. So they asked some questions such as, do you use the memo? Does it add value? And if you had any suggestions about how to improve the audit process, how to improve the guidance that we provide to you. And there were a lot of suggestions around improving the audit process. They were very valuable and constructive. And the information was used to make some changes to information you all receive ahead of time and to help you with the audit process. And it really helped achieve our goal of strengthening communication and continuing to improve the program. Since the fall of 2014, we've conducted 9 strategic conversations with plans on a wide range of topics. And account managers just wrapped up the most recent strategic conversation on good cause. And the reason we did this one was because plans are now responsible for the intake and processing of good cause reinstatement requests, and that just started in January. And moving good cause from the regional offices to the plans was a big change. And we wanted to see how it was going a few months in and really try to find out if there are any issues that could be addressed and any guidance that would be helpful. And this diagram outlines our feedback loop and the process that we use for strategic conversations. And for the good cause strategic conversation, we work with the Division of Enrollment and Eligibility Policy to check on the progress of this new requirement. And the questions and educational materials were developed to really help account managers have a conversation, check in, see how it was going, and find out if there were any challenges with this new process and any additional guidance that would be helpful. They held the strategic conversation with the plans during the month of April. We typically try to give account managers about 4 weeks to do the strategic conversation. Some account managers set up a special meeting. Other account managers do it during their regular monthly calls. And then after the account manager finishes the meeting, they record your comments and share the information. We then take all of the responses from all the account managers and all the regions and put it together and share it, in this case, with the Division of Enrollment and Eligibility Policy. And they were really appreciative of all of the feedback that's been provided, and they're using it to provide additional information and guidance because that's what was requested with this new process. And by sharing the feedback during the strategic conversation, our parent organizations have really helped improve our processes, and that's our goal. So please know that we encourage you to openly share feedback and that we really appreciate it.
Number 8, this is our Mile High city, Denver. And this is just a reminder that when your account manager comes to you and makes a suggestion, please don't always ask for the written guidance or regulations. Where does it say I have to do this? Because in many instances, they're best practices. They're things that maybe they've learned through their training that have helped some of the other issuer plans make a difference. And so if you don't always ask for regulation, and of course, if you need the regulation and there's one tied to it, we'll be glad to share it. But sometimes there's just not a written guidance. It's really a best practice that we've heard that has worked.
All right, number 7, and this is Kansas City, and report noncompliance. So it is extremely important to have an open line of communication with your account manager, and this does include self-disclosing any issues that you might find, even if by reporting those issues it may result in a compliance action. And report these issues when you first find them, and even before you've determined the full extent of the problem. It's better for everyone to be aware of these issues as soon as possible. And your account manager may be able to help you, especially if the issue is around beneficiary protections. They may know of some guidelines, some experiences from other plans, and the goal really is to work with you.
And by the way, the fountain's blue because, of course, the Royals.
Not that you
We're
were
big baseball.
excited.
We're
yeah.
a big baseball city. What can I say?
All right, moving on.
Okay, number 6. And this is the great city of Dallas. And here we want to talk about conducting internal audits of all your program areas. So if you're a compliance officer or someone that's in charge of overseeing what's happening in your plan, make sure you're doing internal audits. But not only doing them, but doing something with what you find. And we just think that's such a valuable thing to do. So really do those internal audits and do the feedback. We're going to talk a little bit more about that in a minute. But do the feedback back to your leaders to let them know you're finding issues and there need to be resources put behind something when you're finding issues. Come on, slide. There it is.
I know. All right, number 5, Region 5 is Chicago, and oversee delegated entities. In this day and age, plans are contracting many services out, such as enrollment and disenrollment, call centers, mailing services, PBM services, and more. The challenge here is that out of sight, out of mind is not a good mindset when it comes to delegated entities. As the contractor with Medicare, you are responsible for the services provided by the delegated entities. And it's very important to have a regular monitoring and auditing schedule set up to make sure that your delegated entities are doing the work and that they're being compliant with Medicare regulations.
Number 4. 4 is Atlanta. That's the great city of Atlanta. So empowerment comes from your senior leadership. And I really want to spend a couple minutes talking about this and kind of. So I was a director and had 2 compliance officers that reported to me. And my counterpart directors in the operational areas didn't report to me. And sometimes it was a hard row to hoe to try to get them to understand that they had to make some corrections in some of the things that we were auditing and finding. We actually developed, we called it a dashboard. Dashboard seems to be a hot item these days, but this was 12 years ago or more. We actually developed a dashboard that not only told our senior leaders where things were at, but told those group directors where they were failing and where they needed to concentrate on things that weren't functioning right. And they were such things as the call center statistics, different things like that we pulled into a dashboard so we could share it at our leadership meetings so everybody always knew where they were and what needed to happen. And so it's important that your senior leaders know when you're failing in something and when you need to have resources behind it. And then I wanted to share a quick story around a similar presentation that I did at the AHIP conference this year. For any of you who might have listened in or been on that, I had a gentleman that came up to me afterwards, and he had a notebook with him. And in the notebook, he had an HPMS memo, and it was the one about audit best practices. And it was dog-eared and marked up and chewed up. And he said, I just want you to know what I've been doing with this to try to get all of my people involved in what we have to do in implementing some of these best practices. And he'd carried this around for 6 or 7 months kind of as his Bible. And it was just such a great demonstration of taking it to heart and trying to make the changes that make a difference. Philly doesn't want to come up.
No.
There it
we
is.
go. All right. Region 3 is Philadelphia, and that was a perfect segue into number 3, read HPMS memos and ensure implementation. CMS regularly sends out updates, new guidance, information through HPMS memos. It's important that this information gets to the appropriate person in your organization so that they can make sure that the guidance is implemented. And we have really seen how compliance is improved by implementing the guidance in the HPMS memos, the readiness checklist, the best practices memo. There's very good information. We're not saying that you have to dog ear and crumple pages and write notes all over things, but we really do encourage you to utilize that as a resource. It works, and again, we find that plans that do follow the guidance in the HPMS memos improve performance.
New York, New York. So region number 2 is New York, and we have a close alliance in New York because our consortium administrator that we report to is in New York City. So New York is about routine monitoring and reporting, and it's a lot about what we've been already talking about that we want you to do, but we want you to know on our side that we also do constant monitoring and reporting, and that's one of the job of the account managers and the caseworkers in the regions. So we monitor everything from CTM closures. Are they appropriate? Are we seeing things close? Are we seeing repeat cases come back? So all kinds of monitoring. We have an account management dashboard where we actually go in and look across metrics, and then if we see problems, we're going to want to address it with you and let you know that we're seeing something here that doesn't look right. Can you help me explain it? So it's one thing you might hear from your account manager. I've been monitoring something and it doesn't look right. Can we have a discussion?
And number 1, and there's Boston, is improve the beneficiary's experience. And so this is really, of course, number 1. This is our goal. We are all here to help our Medicare beneficiary. And we're very passionate and care about how managed care does make such a difference in helping the beneficiary, as demonstrated by the story that Judy told earlier. And so when your account manager is giving you direction or asking you questions, it's really because they want to improve the beneficiary experience. And CMS also needs and values your feedback so that we're able to improve processes, improve guidance, and improve our ability to work collaboratively with all of you to achieve our goal of providing access to high quality care to our beneficiaries. And it's by working collaboratively that we're able to do that. So that's our top 10. And now we want to go to go to questions.
Okay, do we have any questions from our in-house audience? If you could please tell us your name and where you're from.
Sure. Good morning. I'm Sarah Lawrence with Anthem. The number 9 on your list is of particular interest. We've had the opportunity to participate in all 9 of the strategic conversations with our account managers in Region 5 and have found them invaluable. What we're wondering is the process as you've accumulated all that information from plans across the country, how can plans get that information back? There's always a section of the strategic conversation around best practices, recommendations. That would be really, really helpful for us to hear about.
Well, we will be happy to work with our account managers on sharing more information back. You have seen some of the improvements that have been made, but we can certainly work to share more of the information.
Yeah, that would be very helpful. Thank you.
Yeah, we'll tie it all together. I understand what you're saying. So while you might see an HPMS memo that gets driven off of what our findings are, it would help to know that it came from a strategic conversation. Is that what you're saying?
Yes, and really what were the other suggestions? They may not all make it into an HPMS memo, or result in a procedural change, but it would just be helpful for us to be aware. That would be great.
Good
Thank
idea.
you.
Thank you.
Okay, excuse me. We do have some questions here from our virtual audience, so I'm going to go ahead and ask those. The first question that I have is, what if I feel that my account manager is more strict than other account managers, and it seems very inconsistent?
Very good question. You want me to run with that?
You go ahead.
If you have an account manager that is overzealous and you feel that you're being treated differently, we certainly want to hear from you. Both central office people and us would certainly like to know. But do keep in mind, an overzealous account manager can also drive you to excellence. So try to be understanding. But if you really think you're being treated unfair, we certainly would like to hear from you.
Okay, thank you. Next question that I have from our virtual audience. I participated in one of the strategic conversations a few weeks back and haven't gotten any feedback. When should I expect that?
Well, your account manager will share information with you, and you have, as we just mentioned, you have received some of the results of strategic conversations, and we can certainly work to link it all together for you and close the loop.
Okay, thank you. And by the way, the in-house audience, at any time you may stand up and go to the microphone in the center of the aisle. The third question that I have from our virtual audience: if I self-report an issue, will we still get a notice of non-compliance?
It depends. And I know that may not be the answer you're looking for, but it really does depend on the situation, what the issue was, what the area was. Do you have anything more than it depends, Judy?
I think it's important for you to remember, if you don't self-report, we're probably going to hear about it anyway. And you know, we certainly appreciate it coming from you rather than our finding it. And the decision on a notice of noncompliance is really depending on the impact to the beneficiaries, how many, how big is it, how quickly are you fixing it. But the account managers are required to report whenever you're noncompliant and to record it. So you should expect a letter of noncompliance probably whenever we're finding out you're noncompliant.
Okay, thank you. We do have a question from one of our in-house members, so please.
Good morning, I'm Mark Jaffe, and I have two questions which are related, which really deal with nuances to your answers. With regard to self-disclosure, you said, you know, we want you to self-disclose, and I understand that. Periodically at conferences, I've asked the question, plans typically have a very large number of pretty minor issues that might happen as a result of systems and things like that, and the response that I've gotten is, well, there needs to be a sort of a practicality component that we don't want to be, the regional offices don't want to be inundated every day with very small little things. So my first question relates to, what are your thoughts about, sort of in reality, do you want to hear every single possible, you know, non-compliance issue, or is there a reasonableness standard? Why don't you go ahead and answer that, then I'll ask my second one.
I would say this is a very good discussion for you to have with your account manager, and talk through some of those situations and have that conversation about what does self-disclosure look like, what's too big, what's too little. Our goal is open communication, so talking about these kinds of issues is what we want. And then your account manager will be able to, you know, talk about that with you, you know, together to get a sense of what is the appropriate level, when do they want to know. Judy?
I think it's important, too, to understand it's not always about compliance. It's about how we can help with the situation. So let's say you have a hiccup in a mailing and the wrong things go to wrong people, or something like that. We can actually head some things off at the call center. So if we can inform our call center that that something's happened, and that you might get calls about it, and they can kind of head those things off at the curve to say, yeah, we're aware of this, the plan's working on it, contact your plan. So there's a lot we can do. Again, if it's one beneficiary, visit with your account manager. It always depends on what it is. A HIPAA violation is always important, even if it's just one. So it just kind of depends on what it is. So like Brenda said, visit your account with your account manager, and if he or she thinks they're getting inundated, they'll work with you on the issues.
Okay, that's helpful. The second question relates to your comment that, when do you self-disclose? And I think your response was as soon as you know there's an issue. And I also think here there are nuances because, I continually advise clients that you don't want to wait until you've collected all the information. On the other hand, at day one, you really need to collect a certain amount of information in order to convey the nature of the issue to the regional office. And I think part of it is that there needs to also be a reasonable standard. If it's something that is of great urgency, sensitivity, beneficiary related, then obviously, the sooner the better. On the other hand, if you're going to raise an issue and there's an immediate follow-up question and you don't know it because you just found out about it a half hour ago, you're not going to appear that smart. So I guess my thought is in deciding when to self-disclose, to me it makes sense to do it as quickly as is reasonable, but there are nuances there. So any thoughts about that?
Well, I agree there's always nuances, but the more you can keep your account manager informed, hey, we've discovered something, we don't know how bad it is or how deep it is, they might have a specialist in central office that maybe should be working with you on the issue. So just let them know, and then keep them informed as you discover more and as you work to fix it.
Thank you.
I know that doesn't entirely answer your question, but it's so subjective on what the issue is and the impact, and the sooner we know, the sooner like I said, we can advise the call center. We can head some of the problems off that you might be seeing. So,
Thank you.
thank you.
We have another question from an in-house member. Go ahead, please.
Good morning. I'm Michelle Johansson, and I'm from Formularies. So we're a pharmacy benefit manager, and we don't have the pleasure of working directly with the regional offices, but we have health plans in multiple regions. And we're finding inconsistent information or instructions with regard to self-disclosure. So we believe in self-disclosure and supporting the clients in that. But then some regions are saying, for example, that they expect a beneficiary impact analysis in 5 days, which is operationally quite difficult depending on the nature of the issue. And then in other regions, we're not hearing a day amount at all. And so I guess the question is in understanding the difference between a best practice and a regulation and, trying to achieve the best, is there an actual standard from a central office perspective on the turnaround time for beneficiary impact analysis? And if there isn't a standard, would it be possible to attempt to negotiate based on the nature of the issue and the nature of the beneficiaries impacted?
Well, I think you raise a very valid issue. Do you want me to jump into this, Brenda?
You can go ahead.
I do think you raise a very interesting issue, and account managers work closely with our regional pharmacists on impact analysis. So they do have a timeliness factor, and they should be sharing, all regional offices should be sharing that with you. But when it's just not able for you to do, you just need to keep sharing that with your plans, who should be sharing that with their account manager, so that they can understand you're working on it, you're trying to pull it, but it's not always doable in 5 days. So there is a standard.
Okay.
But if it's not reasonable, please, we want to work with you, and we want to work with the plans to get anything correct. So, and then we also want to know if it affected other plans. So, as you would identify it through one plan, we want to know what the issue is downstream for all the plans that you might be the PBM for.
Thank you. And may I ask one more tag-on question? So I love your slide about there's not always going to be regulations or guidance, and I'll definitely fess up to being one of those individuals that asked for that. Would it be possible then at least to identify where something is a best practice, and again, there's a level of flexibility? Because if we hear from one region that CMS expects a certain thing, our goal is to apply that standard across the nation. But if there is no regulatory support and it's merely a best practice, then we have to make a good business decision about operationalizing that again. So we just want to be compliant, but we need to know where the
When there are
compliance is required.
regulations and not a best practice that they can share with the account managers should have that regulation and should be able to share it.
Thank you.
Thank you.
Okay, thank you for the questions. We are out of time, so any additional questions that we receive, we will answer at the end of the day during the open Q&A session, so please be assured that we will address your questions then. And I would like to thank Judy and Brenda for sharing information to drive improvements at CMS and also for the top 10 today.
Thank you all.
Thank you.
All right, it's time for our first session evaluation, so please take out your phones if you're going to text, or your tablets or computer or smartphone, and go to the Poll EV link. So, if you would like to evaluate the session, and we encourage everybody to do so, please go ahead and enter A in response to the question, I would like to evaluate session 1. You should receive, in response, a link that says, hello, please evaluate this session using this link. Go ahead and click on that link. And I promise not to walk through all these instructions every single time. Go ahead and select the link, and then when you get the next screen, go ahead and click on Start. And then you will be presented with the questions one at a time. Select your answer and hit Next. There's a total of 4 questions, and when you've gotten to the last one, you will just click on Finish, and that will submit your answers. Our next speaker today is going to focus on the technical and operational aspects of encountered data submission and CMS's current and planned efforts to assess and improve the data collection process and data quality. Sharing this information with us from the Division of Encountered Data, please welcome Shruti Rajan.
Good morning, and thank you, Stacy. Today, I'm going to talk about Medicare Advantage encounter data from an operational perspective, focusing on how far we've come since 2012, when CMS first started collecting MA encounter data, and then discussing the challenges and opportunities that we still face. Okay. I wanted to start with an overview of the presentation. We'll begin with a brief history of the MA Encounter Data Program. And then next I'll discuss a couple of aspects of MA Encounter Data that are important to bear in mind when thinking about operations. The third part of the presentation will be about the current state of MA Encounter Data collection. Where are we? And the final section will be to discuss next steps in the evolution of submitting and collecting encounter data. So I'll talk about the MA encounter data integrity plan, process improvement, and present a couple of preliminary analyses. Okay, so the history of MA encounter data. Most of you here are probably familiar with the evolution of the Encounter Data Project, so I'll be brief here. The Inpatient Prospective Payment System Rule, IPPS, was published in 2008. This rule clarified CMS's authority to require Medicare Advantage organizations and other entities to submit encounter data for each item and service provided to Medicare Advantage enrollees. So consistent with this authority, as everyone here probably knows, CMS began collecting MA encounter data in 2012. And so why do we collect encounter data? What are some of the uses? And I've listed them here in the slide. The sort of primary and apparent use is for program administration and payment. But there are other uses that are important, such as program integrity, demonstration projects, and research. And so because of all these uses, the success of encounter data implementation and collecting accurate and complete information is important, and it has ramifications beyond day-to-day program administration. So since 2008, CMS, along with our Medicare Advantage community, has worked to successfully stand up this system, the encounter data system. And I won't go into detail here about all the various subsystems we use to perform the editing and processing and storage of the encounter data. What I'd really like to focus on is where do we go from here operationally? Now that the system is in place, we're at an important and exciting juncture for encounter data, where we're beginning to think about operationally, how do we improve the process? How do we assess the data quality? Okay. Yep. Okay. Before I talk about specifics, I wanted to talk about two aspects of MA encounter data that are important to think about in relation to operations. And the first point is that encounter data is big data. And it's a key fact to remember because all of the challenges and opportunities that come with big data are also there with MA encounter data. Now, big data is a term that's, increasingly, you hear it all the time. It's about data sets that are so large and complex that everything about them, from collecting the data to storing the data to analyzing and validating the data, it becomes more complex. And so MA encounter data fits the model. People usually talk about the 4 V's of big data, so I thought I'd go through how that applies to MA encounter data. The first V stands for volume, and that refers to the quantity of data that's generated and stored. And I think the key distinction here is that big data is not sample data. It is a complete record of what happens, and it tends to grow over time. And this is true of MA encounter data. So, we are observing and tracking all the services that are provided to MA enrollees, and as the MA program grows, so too will our data. The second V stands for velocity. And in this context, that has to do with the transactional nature of the processing. So we're getting in large volumes of data, and the goal is to process it quickly and provide access to it, pretty much in real time. And that's a big task. The third V stands for variety. And in the context of big data, that's really talking about the content, the type and nature of data. And in the case of MA encounter data, what that means is that as everybody knows, we're collecting data in a standardized format from hundreds of different submitters who all have their own different data systems. And so pulling all of that together, there are a lot of challenges with that. And then the fourth V stands for veracity. And what that's really referring to is the quality of the data. And as you can imagine, if you're collecting data from hundreds of different systems, the quality of the data is going to have a lot of variation, and it's difficult to think about how to assess it. So MA encounter data is big data, and that's important to bear in mind. The next sort of contextual point I wanted to make was that encounter data is not claims data, and that seems like an obvious point, but it's important to think about because operationally it has an effect. So both encounter data and claims data are conceptually equivalent in that we're basically providing information about medical services that are provided to a patient. But operationally, the key difference is kind of the path that they take. So a claim is a record of a service that's submitted directly to CMS via the MACs, whereas encounter data is really a record of a service that's reported to CMS by MAOs or their representatives. And kind of the uses of those data and the path that they take to get to us really do have an effect from a data processing standpoint and the decisions that we make about how to process that data. Okay, so the next section really is about where are we. Just wanted to give people a sense of, where we are in terms of submission, how has it looked over the last 4 years. I'm just going to quickly go over, very broad brush, a description of submission requirements. Medicare Advantage organizations, as you know, are required to submit encounter data from all types of services for each item and service that's provided to an enrollee. These data are classified in sort of 3 modules: the institutional, professional, or DME, durable medical equipment. And they must be submitted on the 510x12 format. So, and then, MAOs, or they can hire third-party submitters to submit the data on their behalf. So, and then we do have frequency guidelines that are based on the size of the contract. These are sort of minimum guidelines, so MAOs are free to submit data more frequently, but it's kind of a minimum submission frequency guidance. So if the contract has enrollment that's greater than 100,000, the data should be submitted weekly. If enrollment is between 50,000 and 100,000, the data should be submitted every other week, biweekly. And if enrollment is less than 50,000, we suggest that data be submitted monthly. So how are we doing with that? Overall, in terms of getting MAOs into the system and submitting data, we're doing well. 99% of MAOs are submitting data and have been for the last few years, and we have just a handful of small entities that require some technical assistance to complete the end-to-end certification process so that they can begin submitting data. Oops. Okay. So we did some analysis on the submission requirements I just mentioned, the frequency of submission. And this slide shows how well contracts are faring with regard to that guidance. In calculating the percentages that you see in this chart, we opted for a broad definition that would give credit for all files that were submitted regardless of the interval between submissions. So we measured the frequency by counting the number of files submitted over a given year for a given contract, and then we divide by the maximum number of times over the year that the guidelines suggest. So, for example, for medium-sized contracts, the suggested guideline is biweekly. So the maximum number of submissions over a year would be 26. And so if contract A submitted 18 files over the course of 2015, even if all 18 files were submitted, say, in the first 9 months, we would count all of those. And so the percent would be 18 divided by 26, which is about 69%. And so in this chart here, what you're seeing is the yellow is 2013, the green is 2014, and the blue is 2015. And the percentages shown in this graph really are the number of contracts, or the percentage of contracts that have met the compliance requirement. So we have the biweekly, the monthly, and the weekly, and we've seen improvement year over year across time. So the blue bars are higher than the yellow bars. For our small contracts where the guidance is to submit monthly, we can see that the percentage satisfying the guideline has increased from 47% in 2013 to about 64% in 2015. And you see a similar trend for the medium contracts. Those are the biweekly. That's the left-hand bars. We started with 8% in 2013, and we're up to 29% in 2015. And then finally, for large contracts, the requirement is weekly submission, the guidance. And what we're seeing is that many of the large contracts are actually submitting more frequently than weekly, so they may generate files every day or every other day, and some of the large contracts are submitting pretty frequently. But we're also seeing improvement in the frequency of submission there. We began with about 22% in 2013, and we're up to about 56% in 2015. All right. This next slide, and I think I did want to make one more point about that last slide, which is we do want to continue improving on that metric. So we will be planning to provide more feedback on frequency of submissions, as well as beginning to work with MAOs and their submitters to improve those rates. Okay. current enrollment and submissions. So this slide shows how encounter data volume is increasing. It really kind of gets to the first V, volume, as our enrollment grows. I do want to make a point here. The years are dates of service. So it's the volume of records by the date of service of when that record occurred, not the submission date. And that's why the 2015 bar looks a little smaller than the 2014 bar, because we're still getting our records for dates of service in 2015. And you can see here that we've gone from just under 350 million records in 2013 to just over 450 million in 2014. And our forecast for encounter data records for services rendered in 2015 is about 532 million. So, and then the line here is showing you how the enrollment is growing. So. Okay, this next slide provides an idea of the overall size of MA encounter data, and again, the point about how it's growing. We received about 53 million records in April. We're anticipating receiving about 600 million records for this calendar year. And so if you look at the 4-year period from 2013 through 2016, we estimate that we'll have just over 2 billion records. And this is a slide that shows a map that presents encounter data records per beneficiary for 2014, dates of service 2014 across the country. And the orange areas are showing the highest volume per beneficiary, and the blue areas are showing the lowest volume. And operationally, really what we tend to focus on is overall volume, because that's really what we're processing. So this is sort of the next step in an analysis that's kind of calculating volume by enrollment. So just wanted to show that. Okay, and then we also tend to look at the encounters per beneficiary by type of module. So we have institutional, professional, and DME. DME is on the left in yellow, institutional is green, and professional is on the right in blue. And I want to point out again that the year is the date of service, not the submission, which is why 15 looks a little bit smaller than 14. But because we're controlling for enrollment here in this chart, we wouldn't really expect that the volume by the type of service is actually going to change that much. And so that's really what we're seeing. So if you look at the DME bars, they're pretty much the same across. The institutional are pretty close to being the same. And professional, 2015 looks lower because it's not complete data. We're still getting that data. But so this sort of shows what you would expect. If you saw a lot of variation here, you might be concerned about what's actually happening with the submission process. Okay. So the next step, so what's next for encounter data? Now that we've emerged from the sort of initial stage of standing up a national data system, we're setting the groundwork for thinking about process and data quality improvement. And really, we have two key components that we're focusing on. The first is a continuing collaboration with the industry to improve encounter data submission and processing. And the second part of this process improvement is to implement the encounter data integrity plan, which I'll describe in a second. So before I discuss those two activities further, I wanted to talk a little bit about process improvement, sort of where are we and kind of what do we know. There's some known issues. Overall, we've seen that the rejection rates are coming down. They've been cut by about half between 2012 and 2014. I think currently we're running about a 4% rejection rate at a record level. And we've been working to identify the most frequently occurring error codes through internal analysis, but as well as through questions from submitters. And so I've listed the top 3 most frequently occurring errors here: duplicate records, issues with individual identification numbers, and mismatches in demographic characteristics. And we're working to develop additional guidance and resolutions to these errors, investigating exactly what's happening at a record level, and understanding what our system does, and coming up with some guidance. We'll be communicating our resolutions to these issues through various formats, newsletters, but also a return to user group calls. So the current plan is to begin user group calls again in June. June 23rd is the date that we've set to start those calls again. That's the third Thursday in June. We'll be posting dates for upcoming user calls. We intend to continue those monthly on the CMS Technical Assistance Registration Service Center. I'm sure most of you are probably already subscribed, but it's www.tarsc.info, TARSC. So we also recommend, if you haven't already, to continue to subscribe to the email updates on the Customer Service and Support Center, the CSSC website, because we post information all the time, and so the way to be alerted about the latest postings is to register for those email updates. Okay, so process improvement, low volume and submission process. So what can you do if your contract's volume of encounter data is not consistent with what you're and the MA Pro volume overall or fee for service as seen in the report card that we've been producing, and you think that it's due to submission issues? I think the first step here is to review and verify the various reports that our systems generate and send back to the submitters. So on the front end, we have file level rejection reports and record level rejection reports. And then on what we call the back end, we do more record level checking, and we generate a report called the MA002. So we recommend that you really try to look at those and verify what's in those, and ask questions if you're seeing things that don't seem right. The next step would be to make sure that you review the guidance that's available on the website, csscoperations.com. And then correct and resubmit if you feel like you have gotten the answers, or otherwise please contact us with questions. We do want to hear about anything that you're seeing that does not seem right. So our mailbox is encounterdata@cms.hhs.gov. And then another way to improve the submission process relates to self-assessment of encounter data completeness. And so we have some suggestions here. There are a number of different operational analyses that could help an organization understand their data and how complete it is and how accurate it is. And so in the next couple of slides, we've listed a series of questions that would lead to analyses that could be done to take stock of your own data. So, the first would be looking at how does your contract's volume of encounter data by type of service, professional, institutional, DME, compare to the fee-for-service and MA benchmarks, as shown in the recent report cards. How does your contract's volume of inpatient encounter data compared to the no pay inpatient claims as shown in the most recent report card? And I will talk about that a little bit more in a second. What is the distribution of your encounter data records by type over time? Is it consistent? Is it what you would expect? What is the relationship in your contracts data between service categories? So what's the relationship between the primary encounter and the specialty encounter records that you're seeing? Does it look like what you would expect? And that question actually relates to the first question here on this slide. Do the patterns of care in your encounter data align with the model of care that's used for your plan or your contract? Are you submitting encounter data for all services, including those that are outside of the risk adjustment process? Is your contract's encounter data consistent with the content and volume of your medical record documentation? So, all kinds of analyses that can be done to self-assess where the quality of and completeness of your own data. Okay, so the data integrity So CMS has developed an MA Encounter Data Integrity Plan that has two major goals. The first is to validate completeness and accuracy of encounter data and really improve the data for use in program administration and payment and for the other uses I mentioned earlier. And the second goal is to continue our dialogue with the MA organizations on improving encounter data quality and completeness and the submission process. So we really do want to continue the dialogue we've started and think about best ways to improve encounter data submissions. Okay, so validating encounter data refers to the last V, veracity, that I mentioned when we were talking about big data. So, in order to achieve this goal, how do you assess completeness and accuracy of data? And really the core activity here is analysis of the data submissions. So many of the same questions that I just listed a few slides ago are the same types of analyses that we might be thinking of doing to look at what is the data showing us, does it seem reasonable? We might look at things like verifying the integrity of specific data fields. So if I picked 10 key data fields and I looked at them, what % of the data is missing? Are they 99% complete? What % of the values that I have are valid? Things like that, which some of the automated checks do capture that, but this is sort of looking at it just one layer deeper. Analysis of volume and consistency over time. So things like that. And then the second major goal of our integrity plan is submitter outreach. So this has to do with the dialogue back and forth, communication of findings from our analyses to the submitters. And for a start, what we've done are the report cards. We distributed our first round of report cards in September 2015 on encounter data volume. And this slide says April, but it's actually today. We've loaded the data into the HPMS system. And so the second round of report cards should be ready today. In the first release of the report cards, we provided contract level, MA, and fee-for-service numbers on encounters or claims per 1,000 enrollees. So it was a national perspective relative to a specific contract. And in the second release, which has just been posted, we're including regional level MA and fee-for-service volume per 1,000, and that was a suggestion from the submitter community. So we've included some regional benchmarks to look at. Going forward, we actually plan to provide additional operational information regarding the frequency of submissions, even more data on volume, and the first part will be sort of integrity of specific data fields. What do a key set of fields look like? This work is underway, and we expect to be discussing it and presenting it during user group calls in coming months. So. Okay, I just wanted to give you a glimpse here of the first 2 pages of the May 2016 version of the report cards. There are 5 bars for each year, and from left to right, they represent the contract. The yellow bar is the contract, the MA region volume, the MA national volume, fee-for-service region volume, and fee-for-service national volume. The second page there on the right-hand side shows those same volume, but broken out by professional and inpatient services. The remaining pages of the report card also present the same volume metrics, but for outpatient and DME services. And we've also provided a comparison of encounter data inpatient records to an external source of data that we call no-pay claims, no-pay inpatient claims. And those are actually claims that hospitals submit through a separate program, the disproportionate share payments and medical education payments program. So it's through a separate program, but it is complete inpatient claims data. And so our assumption is that if there is a no-pay claim, we should be seeing that in the encounter data. So that'll be in the report card as well. We also have technical notes in the report card that describe the methodology for how we did that match and what the ratios are telling you. So as I said at the beginning, the MA Encounter data system is a national data processing system. It's large and complex, and it's big data. So we really do have some challenges as well as the opportunities for visualizing the data, looking at a massive amount of data. So there's a lot there. And standing up this national system has been a major undertaking that I think CMS and the MAO community has faced. And now that we have a system in place, the next stage really is to take the next step and assess and improve our data quality and our submission process. In closing, we ask that submitters join the user group calls. As I said, the first one is scheduled for June 23rd, and sort of times and more details will be posted on the TARSC website. We also suggest, send samples of your problematic data to CMS. A sample of 10 to 20 records will suffice, and please remember, don't include the individual identification numbers, the HICNs, in that sample data, but it helps us to investigate and debug what's happening and get information back to you. And finally, please continue to contact us with your questions and concerns at encounterdata@cms.hhs.gov. Thank you. So,
Okay. Okay, if we have any of our in-house guests who would like to ask a question, please go ahead and step up to the microphone in the center aisle. Please tell us your name and where you are from.
Hi, Scott Levine, Affinity Health Plan. Very interesting. As you know, I don't have to tell you that in general, the encounter data for MA plans is significantly lower than the corresponding fee-for-service claims data. Does CMS have any thoughts about that, why that is, what it really means?
We've actually just started doing that analysis, so we're seeing the same differences that you're seeing. I think we haven't had. I think our next step really is to investigate why we see the differences that we're seeing and try to tease out how much of it may be submission and people still gearing up to get us all of the data, and how much of it may be other factors like case mix and whatnot. So yeah, I don't have a solid answer for you, but we do intend to look at that.
If you are able to come to any conclusions, I think that would be very useful and interesting information to share with the plans.
Thank you.
Thank you.
Yeah.
Hi,
Hi.
I'm Lynn Wardinger, and I'm with Geisinger Health Plan. And my question is, do you have any update on the MAO 004 report? There have been ongoing issues with that, and especially with the call letter that was released, it's going to be more and more important for 2017.
Yes, yeah. We appreciate your patience as we work through the issues. We've gotten all the questions in the mailbox. We're investigating a lot of the specific sample data that people have told us, and we do expect to provide more information in coming weeks.
And I have another question
Sure.
that kind of tags off of one of your last slides here, and this. You said if we encounter, problematic data, to send you a sample, but don't send the HICNs. But one of our problems involves with the 004 and the HICN itself.
Right.
With a character on the railroad board
Right.
numbers, and makes the number unusable.
Right.
So
I know we're looking into that issue specifically, and we do really expect to have resolutions in coming weeks. So yeah, I know you can't send that in, but yeah, we are aware of that
Would
issue.
there be a way to redact a portion of the number if we wanted to send you an example of something that involved a HICN, just for future reference, to exit out all but the last four characters, if that's where the problem was, something like that?
You know what, let me ask about that. I think that may be reasonable, and I know that you're probably providing the ICN, or the actual claim control number,
Yes.
in the sample. Okay, and that helps us a lot too. So okay, and so are you wanting to show that HICN so you can show us what the actual problem is in
Well,
it?
I'm just trying to think ahead of,
What
if this is the way to get you to know what problems we're encountering,
Yeah.
and we have a problem that involves the HICN,
Right.
how do we let you know if we can't send it?
Yeah, and I think redacting, I think that's actually a good suggestion. So that, I mean, I will definitely, I have that in my head. I'll take it back to our team and we can definitely discuss that. It's a good suggestion. Thank you.
Okay, thank
Yeah.
you.
Good morning.
Hi.
I'm Leslie Berkey-Heiser with Cigna Health Spring. Thank you first for the very helpful presentation. It was very informative on the EDS process. Just a quick question with respect to supplemental data. I noticed that you didn't provide any specific information on it and was curious what you might say across the country with respect to supplemental and EDS.
That's a question that I'll take it back to the team. I don't have any specific guidance on that right at the moment. So, I will definitely take that back and we can discuss it and hopefully provide some guidance.
Thank you.
Thank you.
Okay, we did have some questions from our virtual audience today, so thank you for sending those in. And again, if we don't get to all of them, we will certainly address them later on today. The first question is, has CMS defined an audit process for encountered data?
Our first steps will be to pursue the MA Encounter Data Integrity Plan that I just described. So that involves a lot of different analyses, as I said. So as we conduct those analyses and have findings and develop ways to share that, that would be really our first step in sort of evaluating the data. So.
The second question we received, with only 15 minutes dedicated to ED updates, is there any plan to return monthly user group calls? As we become more familiar with submissions and returned responses, it would be helpful to open dialogue regarding remediation and what is expected.
Well, that's a good question. Yes, as I mentioned during the presentation, we are returning to user group calls. June 23rd is the date for our first call, and we will probably be discussing some of the known issues that I presented on that slide, what we're finding on that call, and then we do intend to continue those monthly going forward. Information will be posted on www.tarsk.info.
Okay, the next question that we have received. I understand that CMS will be reissuing the MAO 004 reports. Is there an ETA on when these updated reports will be available?
As I mentioned before in response to one of the other questions, we have been investigating all of the issues, and we really are trying to go through row by row where we have been given sample data. And so since the initial release, we've been working on the issues we've heard of, and we will be addressing the MAO 004 reports in coming weeks. So.
Lots of questions. Another question we received. I understand, oops, I already asked that one. I don't think you want to hear that one again. We have heard that CMS will be reissuing all of the MAO 004 reports. Is this true? If so, when does CMS expect to reissue the reports?
Okay, so I think that's very similar to the question before, and as I said, we are looking into it, and we will definitely be addressing these questions in coming weeks.
Another question from our viewing audience. When does CMS plan to reinitiate user group calls? You already answered that.
June 23rd.
Okay. All right, we're moving on. The next question, how complete is the encounter data?
That's a good question, and as you can tell from the presentation, that is really the next step that we're taking, assessing the completeness. And quality of the data, I think what I can say is as the more encounter data becomes a part of the actual payment process, the more complete it will become. So we've laid out a transitional plan in the payment notice, I think, which establishes a reasonable glide path for achieving a sound level of accuracy and completeness in the data. And we hope that as submitters continue to assess their own data, that they will communicate with us and tell us what they're finding so that we can overall improve the process.
You know, we were just checking to make sure you guys are paying attention out there. All right, another question we have. Who is the contact person in CMS to address questions regarding merger of two plans into one plan regarding RAPS submission process and encounter submission process related to third-party submitter? It is not being addressed in the CMS terminated contract memo.
Okay, I think that this question, I'm going to take it, now that I see it as a question, I will definitely take it back to the team, but I would recommend questions like this be submitted to two mailboxes, the encounter data at cms.hhs.gov, as well as risk adjustment at cms.hhs.gov. So if you submit it to both of those, because the RAPS data system and the encounter data system are two parallel but separate things, we can take that into consideration and develop some guidance.
Okay, and that is it for our questions for Shruti. So I would like to thank Shruti for joining us today. Oh, I'm sorry. We do have one more question. It's in-house. Sorry. Go ahead.
Thank you. One quick question. I'm accustomed to the annual attestation for RAPS that you're attesting to accuracy, completeness, and timeliness. Does that automatically apply to encounter data in the same attestation moving forward, or has that not been instituted yet?
Yeah, that has not been instituted yet. I know that we will be working on that and providing some more information about the attestation. Okay. So, yeah.
Great. Thank you.
Yes, thank you. Okay, I think that's probably it.
Okay, well, thank you again for joining us today, Shruti. Okay, it is that time again to go ahead and evaluate the session. So either text in the letter A or go to pollev.com, CMS 2016 Spring, and go ahead, put the A in, follow the directions, and you can evaluate this session. Okay, our next speaker will provide you with an overview of quality measures released by the CMS Office of Minority Health and discuss how these data may be used for quality improvement efforts. From the Office of Minority Health, please welcome Madeline Shea.
So good morning. I am really excited to share with you, for those who don't know, that last month we released, for the first time ever, HEDIS and CAPS measures stratified by race and ethnicity to help all of you to understand where we have disparities and where we can improve. So before we go into this, we're going to have a little polling question. That did not pull up.
We're having a little bit of technical difficulty. We'll get there.
Here we go.
Oh.
Okay, perfect. So, we're going to ask you to choose to choose the responses that apply. You can choose as many as you would like. I would describe our experience with stratified reporting as: we have a good process in place to collect racial and ethnic information from all members. This is our first time looking at HEDIS or CAPS measures by race and ethnicity. We provide our practices with dashboards of key quality measures by race and ethnicity. And we have quality improvement processes in place to address health disparities. And let's give you a minute to get your responses in. These are looking pretty solid. So then I'm really excited that I'm here to talk to you today, because it looks like almost half of the people who are participating are just looking at their measures for the first time today, stratified by race and ethnicity. So this is a great time to be introduced to your work. So you might be thinking, well, why are we doing this? Despite advances in access to care, increased spending for health care, and improvements in quality, racial and ethnic minorities continue to experience worse health outcomes. And so we want to reduce these disparities. And in order to do that, we need to have a systematic, standardized way to collect data, analyze it, and act on it. We do have authority to do this. The Affordable Care Act mandated improved data collection standards for race, ethnicity, primary language, sex, and disability status. Again, it's understanding where we have disparities that will allow us all to address them. Furthermore, the Impact Act of 2014 requires HHS to examine the differential effect of race and ethnicity on Medicare payment policy. So for this report that we released a couple weeks ago, that you can get on our website, we will be showing you where to get this. There's two data sources. One is the Medicare Consumer Assessment of Healthcare Providers and Systems, called CAPS, and that survey from 2013 and 2014. And the second data source is the Healthcare Effectiveness Data and Information Set, called HEDIS, which is data collected from Medicare health plans nationwide. The CAPS survey, as probably many of you know, is administered by mail with telephone follow-up on a stratified random sample of Medicare beneficiaries. In the 2014 survey, 340,776 beneficiaries responded, with a 41% response rate. This represents all fee-for-service beneficiaries and Medicare Advantage beneficiaries from 531 contracts that have eligible enrollees, at least 600 eligible enrollees. So in the Medicare CAPS survey, beneficiaries are asked themselves, so it's self-report, are you of Hispanic or Latino origin or descent, and what is your race? And following the U.S. Census approach, the answers to these questions are used to classify respondents as Hispanic, American Indian or Alaska Native, Asian or Pacific Islander, Black, white, multiracial, or unknown. And in this analysis, we don't look at multiracial or unknown. We we limit it to the designated identified race and ethnicities. For the HEDIS data, there are clinical care measures in 5 domains gathered through surveys, medical records, and administrative data. In 2014, 473 Medicare Advantage contracts with a total enrollment of 13.2 million beneficiaries reported at least one HEDIS measure. Unlike CAHPS data, HEDIS data do not contain the patient's self-reported ethnicity, which of course makes sense given that it comes from administrative data and it's not from a survey directly with the beneficiary. So race and ethnicity is imputed using a method that combines information from administrative data, the surname, and residential location. And we have really good accuracy for this method. It's something that's used here at CMS. It's 88% accurate for Hispanics, 90% accurate for whites, 92% for Asian Pacific Islanders, and 95% for African Americans. And we do, for plans that might want to do these analyses themselves, we are hoping to have a model that we can share with you in about a year. So CAHPS estimates are case mix adjusted for age, education, self-rated health and mental health, dual eligibility, low-income subsidy, and proxy respondent status. Scores on HEDIS measures are not adjusted for these characteristics. So let's dive into what we found and what you can find on our website in this report. Incidentally, there's reports by plan as well as a national report. The reports, the national report is 2014 data, and the plan level reports are 2013 and 2014. So the first thing we see here is that for the 8 CAHPS measures, American Indian, Alaska Natives did worse in 2 of them, 2 of the 8, than whites is how they reported. For 5 measures, they reported the same results, and for 1, they reported better. And so you can kind of follow this across. For Asian Pacific Islanders, we see 7 measures rated worse than whites and 1 better, none the same. For blacks, we see 3 measures rated worse than whites, 5 similar, and Hispanics, 5 measures worse and 3 similar. Are you following me? For those I can see. Great. Okay, so let's look at an example of one of those CAHPS measures. Getting appointments and care quickly. So we can see that there really is quite a difference by race ethnicity in beneficiaries feeling like they're getting appointments and care quickly, with American Indian, Alaska Natives feeling much more positively about this than Asian Pacific Islanders. And then we have the other racial and ethnic groups in between those 2. And then there's another CAHPS measure where we don't see as much variability by race and ethnicity. So this would be on doctors who communicate well. We see that, again, actually for this one, the highest rated is among blacks, with 91.6% rating well their experience with doctor communication. And Asian Pacific Islanders, again, the least favorable, they're feeling least favorably, but the spread is much, much smaller. So now let's look at some of the HEDIS measures, and this is all to whet your appetite to go and dig in after this meeting. Okay, so here we see that for the 27 HEDIS measures, Asian Pacific Islanders actually fare better than white. Little different story than we saw with CAHPS. So 14 of the measures, they're doing better than whites. 10 the same, and 3 worse. For blacks versus whites, we see 10 measures worse, 14 the same, and 3 better. And for Hispanics versus white, 9 worse, 15 similar, and 3 better. So let's see what's going on there. So a measure where we see a bigger spread and more evidence of disparities between racial and ethnic groups is blood sugar control. So this is for diabetes, hemoglobin A1C control. And we see that the control is much better for Asian Pacific Islanders than it is for blacks. And this should be something that I would think you'd want to pay a lot of attention to, because there's a lot that falls out from this. So that is one. But then we have another measure, appropriate monitoring of patients taking long-term medications, where all the racial and ethnic groups do pretty similarly. Just the spread of 94.4% for Hispanics with appropriate monitoring versus 92.6% for whites. Okay, so we're ready for another poll before we dive into what we do about all of this. So here, I want you to check one response. Check the best response to the following statement. We could use support to address racial and ethnic disparities in HEDIS and CAPS measures. Response 1, no, our leadership has not prioritized the reduction of health disparities. Response 2, no, our company does not have the organizational capacity to target health disparities. 3, yes, we want to improve our programs and interventions and need support with a plan. Or 4, yes, and we're ready to develop programs and interventions or have programs in place now. Let's see where we are here. Maybe kind of stabilizing. Give it another second. So again, this makes me really happy to be here because we're seeing that the vast majority of those participating today are looking for support to reduce their racial and ethnic disparities in their measures, and that's what the Office of Minority Health here is here to help with. So, and we'll also look at how we can help with those other responses too. So, on the website where you will find the national report and your plan level reports, you will also find a resource called Building an Organizational Response to Health Disparities. And this is an approach to how you do it that could apply to any one of the measures. So you can get that on our site. It offers resources, guidance for health plans and providers to reduce racial and ethnic disparities in patient experiences and quality measures. And if you remember our first presentation today, the number one goal was to improve or to be about patient experiences and a good experience for beneficiaries. So this is a great way to help you do well there with your account managers. So this has 5 key areas. The first relates to data collection, the second, data analysis, the third, building a culture of equity, the fourth, quality improvement, and then the fifth is interventions. So this first section that relates to data collection, we even just heard in the last session, if you don't have data, if you haven't collected it, then you're not going to understand it. So this is a really critical first step. And the guide will walk you through, and actually, sneak preview, next month we will be releasing guidance on how to collect racial and ethnic demographic information, how to improve your collection of this information, and we'll be getting that information out to you. So, but this is critical. It's the first step on which we build our understanding. The second step is, if you have the data but you never look at it, it doesn't do you much good either. So it's how to use the data that you have to identify disparities, both the data that we're providing as well as data that you have, and establishing a collaborative process to share and analyze what you're seeing. The third whole area that we would ask you to focus on is building a culture of equity. So how to establish an organizational commitment to addressing disparities. And I did see from some of the responses that this is a challenge for some of you. So we have resources and are here to help with that also. And tips for fostering a culture of equity at all levels of the organization. The fourth area is quality improvement. So how to address disparities using a quality improvement framework, such as the Plan, Do, Study, Act framework, or Six Sigma, or whatever of the frameworks that you use in your plans. And then recommendations for infusing disparities focus within your existing quality improvement framework. Fifth is interventions, because ultimately, if you looked at that diabetes measure where there was a big spread, you're going to need interventions to address that. So we offer resources for that as well. And you can go to our guide for quick tips on this, and we'll be, on Friday, we will be releasing a whole guide for targeted interventions for colorectal screening and reducing disparities there, but we'll be rolling them out for other measures as well. So here we, how would you build an organizational response to healthcare disparities? We didn't show you the data for the colorectal screening, but I can tell you that it's another measure that has a big spread, with racial and ethnic minorities doing far worse than whites here. And how you can implement targeted interventions that lower the cost and maximize your quality improvement efforts, as well as reducing disparities among vulnerable beneficiaries. So this targeted intervention is an application of the organizational response whole framework that has a Plan, Do, Study, Act cycle. And if you use a different one, you can plug this in a way that makes sense for you. But it says that first we're going to plan, we're going to analyze what's going on with the data, then we're going to do, and then study and act. I'm going to go to the next slide that gives you some examples here. So for the planning section, let's say that in your plan you see big racial ethnic differences in colorectal screening. So first you're going to want to review the data that we have on our website that you'll have the link for, and really understand what our data is telling you, which is your data. Then you're going to want to look at your own internal plan information and get input from stakeholders on what's going on there, what's the story. This is your understanding so that you can plan what to do about it. And let's just, for sake of an example, say that you're seeing that only 42% of older black members and 43% of members with limited English proficiency are screened. It's not very good. So you want to focus on what's going on there, and you might do a root cause analysis with those as you've engaged your stakeholders on, what do people think is going on? And in doing that root cause analysis, people suggest that people don't know their personal risk for colorectal cancer. That would be one reason why they wouldn't get screened. And also that you don't have any member materials in the languages or in simple English that these populations, that they would really get, that would be motivating to them to get screened. So then, based on this pre-work that you've done, you will, one thing you could do is pilot, is this idea that it's about information, lack of awareness of risk, as well as information that's appropriate for different groups that you serve. Based on that, you're going to pilot what you think would be a good intervention. So the small-scale pilot, your quality improvement team is going to target members, who in an area that's 30% Black and 15% Spanish or Mandarin speaking. And you're planning to mail tailored brochures on the risk of colorectal cancer to these members, and also to the providers who serve them in these areas where you have big discrepancies in your data. And then you're planning for the quality improvement team to collect data pre and post, mailing out this information to see how it works. What's the before and the after in understanding about risk, attitudes about risk, knowledge, and then ultimately getting screened. Oops. Okay, so you do this pilot, and then you are going to look at whether it achieved the results you wanted. What's the result we want? We want to narrow that disparity in those screening rates. So you will see if the post-test shows that Black and members with limited English proficiency, did their perception of risk, knowledge of risk increase? And ultimately, did they come in for screening? So this is kind of how you study what happened. And then finally, after analyzing those results, you'll decide on whether you're going to go with a full-scale implementation of the pilot that you did, or whether you're going to make some adaptations. And that's just a little, in a nutshell, the kind of approach that you would have to reducing those disparities. But we are excited to work on this with you. We do have many areas where there are racial and ethnic disparities that have long-term costs to plans, because we're kind of talking about prevention things here, understanding, the CAPS measures that relate to beneficiary experience have a lot to do with the care seeking and compliance, ability to follow through on health guidance, as well as HEDIS measures, quality measures that relate very much to preventing conditions that can have very expensive outcomes. So that is it in a nutshell, and if you have any questions, please email us at stratifieddataqi@norc.org. And I guess that will be it.
And it's my turn. Yes. It is time now, if you have any questions, to step up to the microphone in the center of the room. Please introduce yourself and tell us where you are from.
Okay, hi, I'm Gita Worcester from UCare in Minnesota. When you had your survey, there wasn't the opportunity, when you say, do you need help? I think all of us need help in improving the care, but my particular plan has a very large portion of its population that are from the Hmong area, Laos, Vietnam, and East Africa. And so when you have the high level of summary information for us, we really need to dig down and we've been doing this. We follow the class standards as an
Yep.
organization. This is probably like hours of conversation about what we've already been doing, but it takes a village, and some of the populations don't have a written language. So is there a way to garner feedback in a more proactive manner from plans that might have some best practices for the new immigrant populations? I totally understand social demographic issues and the social determinants, but we're struggling because there's pots of different new immigrant populations that don't fit into a mold of a normal QI process, and we want to do a good job, but there aren't simple roadmaps for us to follow right now. And the CAPS data that we have been unable to get, and we know from our Asian population, they won't ever give us on a survey a 10 or a 9. They've given us that feedback in focus groups. So I think it's so complex that it's not as simple as maybe the picture you were painting is.
There's a lot to culture and to the way people will respond about their experience. You're absolutely right about that. It's not the reason, though, not to look at the data, and I think that's why in our whole organizational response framework that we've set up, engaging stakeholders, which includes beneficiaries, is really critical to understanding the data. Typically, there will be certain areas geographically, communities, where things will not be working as well. And so it affords you the opportunity to get in there and see, by talking to the providers who serve those communities, and in your case, the Laotian and Hmong and East Somalian refugees, immigrants who've come in and would have a very different experience of care. But that's, as you really refine your model working with these populations that have a lot of barriers and that you probably don't understand very well, it's a great way to really dive into how you do this work across the board for quality improvement to reduce disparities. So, and I think it can be very, just a positive experience for all concerned. So.
Hi there. I'm
Yes.
Judy Ross. I'm with Fresenius Health Plans. We're a new plan in 2016, so we don't have any retrospective data. Can we still access the national data?
Oh, yes.
Okay,
This
so-
national report is available for everybody.
Okay.
Yep.
Thank you.
Okay, we will go ahead and take a question that was sent in from our virtual audience. And our first question is, what do the stratified HEDIS and CAPS data represent?
So in the beginning, there are two different, I described in the beginning of the presentation that the CAPS measures are based on a survey of members, all the different Medicare beneficiaries, about their experience of care. So it represents what we believe is a representative sample of those that you're serving by race, ethnicity. These measures were picked, it's just a subset of what they respond to in their survey, because this subset, we know, has very rigorous, valid, and reliable responses by race, ethnicity. So it represents what beneficiaries themselves are experiencing in their care. The HEDIS measures is looking at quality measures. This is not from the voices of the beneficiaries, but from these other data sources. So it represents quality differences between different groups. So if you look at control of blood sugar, and you see big differences, as we did, by race, ethnicity, that's a hard quality measure. The plan is not doing as well for blacks in that case as it is for, I think it was Asian Pacific Islanders did best in that example. So hopefully that answers that question.
Okay, the next question that we have, are the data shown at the contract or the plan level?
They're shown at the contract level.
Okay, the next question. Are these results included in the MA and Part D star ratings program?
No. This is another resource for plans to use to continuously drive improvements, but it is not the same thing as your STARS measures.
We do have another question. Do these results affect MA contract payments?
No, they do not, but we sure hope that you're paying strict attention to them.
And the last question that I have here today, how can MA contracts use the information to improve quality?
Well, as we like to say in our office, if you don't know about it, if you don't measure it, you can't improve it. So these are your first step to understanding where there is a difference. And we have spoken to some plans in some early discussions to get their response to their contract level data. And in a couple cases, they really weren't aware of these differences. So we believe this is the first step to allow you to do the necessary next steps.
Okay, and if that's all for the questions, I don't see anyone else who has one. I would like to thank Madeline for the overview of how these data may be used for quality improvement efforts. Thank you, Madeline.
Thank you.
Okay, so if you would like to evaluate this session, here we go. Go ahead and, you know the drill, put the A in and follow the instructions. And we appreciate your feedback. Give you a moment to do that. And actually, we will be taking our lunch break next. And we will begin the afternoon session promptly at 12:45. For our in-person guests, the cafeteria is downstairs, and if you pre-ordered your lunch, please pick it up at the Jasmine Cafe, which is right outside of the cafeteria. And for our virtual audience, we look forward to seeing you back here at 12:45. Enjoy your lunch.